Welcome to our webinar series for professionals.
So just everyone, welcome to this webinar on hormones and male hormones in regards to female health. And we have naturopathic Dr. Allison Smith with us today to entertain us and educate us around this event. I've just spent the weekend together with Mark Newman in San Francisco, discussing Dutch. Carrie Jones was there as well, so that's some of you who have already met at some of our events. So yeah, this is just exciting, and we've got lots of people signed in to listen. And remember, those of you who are still considering London, there's still a few places left, but we are getting close to having the rooms completely filled up. So look out for emails in regards to that. And otherwise, let's just get you going, Allison. Let's share
talk about androgens. Great.
Exactly.
I will go ahead and share my screen so we can just
do that.
jump right in. Today, we're going to talk about utilizing Dutch for managing high androgen presentations in women. Oh, here's Teresa. Let me move on to a little introduction about me. I am a naturopathic doctor, but I have practiced for, 16 years since I graduated in 2009. I bring about 10 years, or actually almost 11 years now, of working within the hormone lab testing space. So I worked for ZRT for 7 years. I worked with Dutch for a little more than 5 years now. So maybe we're pushing 12 years. So I've had the pleasure of not only working with a lot of medical practitioners of all different types, from acupuncturists to medical doctors to registered dietitians and others, to help with understanding of how to look at and integrate a case using lab testing around hormones, in particular thyroid, sex hormones, you name it. So lots of different body fluids, and I've probably looked at hundreds of thousands of tests in that 12 years. So I have a lot of experience and seen a lot of different patterns. So a Q&A doesn't scare me. I usually have a lot of ideas to bring to bear. So that's a little bit about me. Today, I would like to spend some time reviewing androgens, what their kind of basic function is and their role in health and disease. I want to talk a little bit about some of the common drivers, but I'm not going to spend a whole lot of time on how, on parsing out the drivers, but I'm going to talk about some main drivers as we tend to see it from an etiological perspective on a Dutch test. LH, insulin, stress, and genetics. We'll concentrate quite a bit on stress. Just admitting some folks. Oops. Here we go. And then symptoms of androgen imbalance. I think a lot of us know how to recognize that, but it's some good reminders. And then talk about the approach to patients presenting with high androgen symptoms, some common serum tests. One of the cases we'll talk about today has a stool testing component. And really, most importantly, how the Dutch test tells a person's androgen story with the new report, because I think a lot of people haven't really had a lot of experience with the new version of the report. So we'll do two cases. One is on a PCOS sort of fertility journey, and the other is a hair loss case. As always, the slides that follow are provided as information resources, and they shouldn't be taken as individual medical advice or as a substitute for professional diagnosis and treatment. Sometimes they're really compelling ideas. Okay, first, let's get acquainted with the androgens. We have DHEA and its metabolites, DHEA sulfate, androsterone and etiochalanolone, and of course testosterone and its metabolites, particularly dihydrotestosterone. Androgen receptors bind androgens. So androgens activity comes through their binding of androgen receptors. They turn on anabolic activities in the body. They build muscle and bone. They contribute to follicle recruitment and development and stimulate growth hormone. But in women, too much androgen can have the opposite effect. When androgens are in their normal ranges, they support follicle recruitment and development. But when they're too high, they can dysregulate follicle development, impair ovulation, and some of the special gifts of androgens are lost when they fall too high or too low. If androgens are too high, it also impedes glucose uptake. So it has to be perfect, and that's really important. Not too high, not too low. Androgens also act as precursors to estrogen. We see this an awful lot with high androgens that often will coincide with elevated estrogens, not always, but they are precursors to the estrogens. So if I give myself a laser pointer here, we can see here's DHEA, farther up in the steroid hormone cascade than testosterone is. But DHEA can turn into testosterone, actually through a couple of different ways. But DHEA can also turn directly into its own androgen metabolites, like androstenedione, that then can funnel back in its own way into the estrogens as well, right? Acetylcholine I was pointing to here. Androstenedione finds its way into the estrogens in purple here. So not only does testosterone turn into estradiol, DHEA can turn into estrone. So in patients with fast aromatase activity, maybe they have excess body fat or adipose tissue around the middle, or an aromatase gene, SNP. These are all ways for androgens to find their way into estrogens, which are also anabolic, similar to androgens, but they have a slightly different profile in the way they affect our fertility. They're more proliferative and immune stimulating. So these are all things that we need to think about when patients have elevated androgens plus issues in any of these areas. Because when estrogen is high, similar to when androgens are high, estrogens can have some paradoxical or opposite effects at the tissue level than you would expect. With those, it's important to assess not only the androgens, but also the estrogens whenever we're looking at a high androgen presentation. So where are female androgens made? There's a significant contribution from the ovaries and the adrenals. Adipose tissue also does a lot of that conversion of DHEA to testosterone and on to estrogens. So in menopause, because the ovaries are much more out of the picture, most of our hormones are coming from adrenal source and also some from conversion in adipose tissue. All right, androgen etiology, clinical signs. High androgen symptoms are usually coming from are usually things like acne or scalp hair loss, hirsutism. They can also present with sort of mental emotional disturbances, irritability and anger are kind of common, or mood swings. Sometimes our female patients will say. And this can be totally normal. High androgens can exist in like a well-trained athlete and not be something to key off on. So doing a good history makes a lot of sense. Low androgens typically will underlie sexual dysfunction or mood issues, sometimes chronic stress, fatigue, things like that. But today we're really going to focus on this high androgen side of things, the hair loss, the hirsutism, the acne, and the irritability, insulin resistance. These are all things you should be thinking about as connected to each other and to androgens. So as a reminder, whenever we're talking about Dutch, we're assessing sex hormones with urine, dried urine test for comprehensive hormones. Dutch is an acronym. So we use urine for that. We do have the ability to look at cortisol with the salivary samples. A lot of the reports we're going to talk about today are Dutch complete tests, which measure free cortisol in the urine. It's all done in urine. But we do have a couple of panels that look at free cortisol from saliva. So we can look at the cortisol awakening response, and that is often a pertinent thing to check out. The advantage of urine is that it measures only free and bioavailable fraction of hormones that were glucuronidated and enter the urine. And they otherwise travel around the bloodstream bound to binding globulins. So serum testing, for all of its value, it has this limitation when it comes to looking at hormones, because our estradiol and testosterone and our most important and potent androgen, dihydrotestosterone, all travel around bound to binding globulins. So does cortisol and progesterone. So we have binding globulins that are causing our hormones in the bloodstream to be unavailable to tissues. And so if we want to figure out what's going on at tissues, without, zeroing in with a microscope and figuring out what's happening at the receptor level, if we want to figure that out in a way that's non-invasive, urine is about the best you can do. It does give you that whole body tissue uptake, utilization, and metabolism, because we're looking through the metabolites by looking at dried urine throughout the day. Additionally, you get that complete estrogen and androgen picture, because we can really zero in on how these things are being metabolized. And today we're really concentrating on the androgen metabolites. So we'll talk a lot about 5-alpha reductase enzyme and how it converts testosterone to a even more receptor ready and high affinity androgen metabolite here, dihydrotestosterone. So back to the androgens, now we kind of understand how we're looking at these things from a testing perspective. Where do high androgens come from? Like, how do the wheels fall off the bus here? That's kind of an important thing. If we hope to detangle that and walk it back when a patient's walking in with infertility or hair loss, we have to kind of understand where we want to work. So there could be high LH levels from the pituitary, like in PCOS, or adrenal stress from high ACTH that pushes DHEA up, metabolic syndrome, which notably has that low sex hormone binding globulin, high bioavailability of androgens at the tissue level, insulin resistance. There are lots of contributors, and all of these can lead to an increase in androgen levels and/or an increase in the formation of highly active androgen metabolites. Okay, so we'll zoom in on DHEA first. DHEA sulfate as a prohormone itself does not bind androgen receptors except in a few special circumstances. But when it enters the tissue from circulation, and it can enter all sorts of tissues, including the ovary, and the ovary can even perform de novo synthesis of DHEA, but it does pull up DHEA sulfate from circulation, and it has all of the gene hardware to desulfate DHEA sulfate and activate it and convert it down into androgens and estrogens. So when DHEA sulfate enters tissue from circulation, it converts to other receptor-ready androgens and estrogens to have its effect, right? So in urine, we're looking at that aftermath in the metabolites. The 5-alpha reductase metabolite does DHEA's work at the tissue level. So for DHEA, we think about androsterone as it has a moderate impact on androgen receptor. It's certainly not as strong as dihydrotestosterone, but a lot of people don't realize, and I don't know that our test report does a great job of sort of showing this, but there is a backdoor, it's called a backdoor pathway, where androsterone can convert directly to dihydrotestosterone in tissues. So, when you have high DHEA production, you do have this potential for your 5-alpha metabolites of DHEA to funnel back into some of the testosterone, or the metabolites we think of as belonging to testosterone can also belong to DHEA. And this dihydrotestosterone and androsterone, when it binds those androgen receptors, contributes to muscle development and strength, like we think of, our anabolic activity from androgens, and also increases, body hair and decreases your scalp hair growth and thins the hair follicle and can cause acne development. So androsterone, we think of down that 5-alpha pathway, activating DHEA. And DHEA has another metabolite that we look at too on a Dutch test. It's called etiocholanolone. It is inactive at the androgen receptor, so it's not the right shape to fit into an androgen receptor. Therefore, it really doesn't have androgenic potential at tissues, so kind of inert. But it is active in other parts of the body. It's not that it does nothing, but it is active in the immune response, and it might act in some situations as a neurosteroid at GABA receptors. Think kind of similar to how some of the progesterone metabolites might work. It's kind of interesting. So when people have acne or oily skin, what are we thinking of? We're thinking of androsterone. We want to make sure that they are not blowing down that pathway too hard. Okay, testosterone also converts to receptor-ready androgens via 5-alpha reductase, similarly to DHEAs metabolism. And the 5-alpha reductase metabolites do testosterone's work at the tissue level. Some even think of testosterone as a prohormone because dihydrotestosterone is so much stronger than testosterone. It binds androgen receptor with higher affinity. It stays on the receptor longer than testosterone does, and it upregulates more androgen receptors. So everything androgen, dihydrotestosterone does it 3 times as strongly as testosterone. So it's responsible really for testosterone's action in the tissue. So when people have acne or oily skin or hirsutism, like we were thinking with DHEA, we think of androsterone. With testosterone, we really think about dihydrotestosterone or DHT. You'll see me write it this way. In women especially, we follow another marker actually, because dihydrotestosterone is formed deep within, the cellular structures. And it does enter the urine when it gets kicked out of the cells, and we do find it in the urine. But the more persistent marker of dihydrotestosterone production in tissues is 5-alpha androstenediol. And this becomes a really important marker, especially when patients have what we call a UGT deletion. And I want to talk about that next. But 5-alpha androstenediol is the most sensitive marker on a Dutch test of tissue exposure to dihydrotestosterone, right? So we think of them as the same thing. So this is why we have it right up front on the summary page of a Dutch report. So that's where you'll find we have 4 elements of our androgen hormone story that show up right up front on the new Dutch report. The total DHEA production, testosterone, and 5-alpha androstenediol. All right, that's correlating with those highly androgenic symptoms. So we need those 5-alpha metabolites to reap the benefits from testosterone, but we do report 5-beta androstenediol so that we can compare the 5-alpha and the 5-beta reductase activity. But really 5-beta androstenediol does not have any of that same androgenic potential. And I call it inert. It probably has some action on the way out, but it's not a very strong androgen. So epi-T is a little bit different. So epitestosterone, I use all the time to help differentiate a premenopausal from a postmenopausal person. You can use it as a way to determine whether or not somebody has a UGT deletion, which we'll talk about next, as an important caveat to urine testing for hormones. So UGT2B17 gene deletion is probably the biggest caveat to interpreting testosterone results from urine samples. And this is because people who carry this gene deletion do not glucuronidate their testosterone and excrete it into their urine in amounts that correlate with circulating testosterone levels in the blood. So essentially, they don't pee their testosterone, right? This affects about 20% of the non-Asian population. So if you work mainly with a South Asian population, you'll see it often. It has a much higher incidence, up to 80% in that population. In like a population, mixed population at large, you'll see it about 20% of the time. This is what it looks like in a female patient. You see that testosterone will be low, very low, compared to epitestosterone, right? This person's pretty robust. And you'll notice these ranges are exactly the same, 2.3 to 14, 2.3 to 14. Typically, we see around a 1-to-1 ratio is typical, with some variance, absolutely. But this is really different. So the 13 being tip top of the range, and the 1 or even less than 1, sometimes you'll see it approaching 0, depending on how strong of an effect that is having on that particular individual. So this is what you're looking for, right? A very low testosterone compared to epitestosterone. And you'll notice that 5-alpha androstenediol is just looks happy. It is unaffected also, similarly to the epitestosterone. 5-alpha androstenediol does not get glucuronidated by this particular UGT gene. And so people who are carriers will still have a 5-alpha androstenediol that's ready for you to look at to determine their 5-alpha status in the body. So we'll just do a couple little practice scenarios. So up top here, we have testosterone and epitestosterone. They're slightly different, but they're pretty close to a 1-to-1 ratio. This person does not have a UGT deletion. Below, we can see that testosterone is really low, but epitestosterone is tip top of the range. And that tells us that we must use 5-alpha androstenediol for our urine assessment. And when you see this, you always want to double check in serum before treating a low testosterone. You wouldn't necessarily say, oh, this testosterone and DHT are so low, I'm going to treat that with testosterone therapy or DHEA therapy or some expensive herbal therapy support that really wouldn't be helpful because this person actually makes plenty of testosterone, right? So check serum, that's the bottom line. If testosterone and DHT are unexpectedly low in urine for the patient's presentation, you want to suspect that they might have a UGT deletion and use serum testosterone to confirm before you initiate androgen therapies. So in summary, maybe the most important thing to remember that in urine, 5-alpha androstenediol is DHT. By all intents and purposes, it is a strong marker of testosterone's activation in tissues. And when you're measuring urine, so use it. It is the one that is not affected by UGT deletion as well. We even published a white paper this last year that describes some of the research around the use of 5-alpha androstenediol as a marker of androgen status in women. So do read through that. We have a nice executive summary if you don't want to read through it all the way. It really is emerging as a more sensitive marker of androgenic effects than even DHT, especially in women. So feel free to download and read this white paper at your leisure. So now that we know a little more about the androgens and how their metabolites function in the tissues, let's look at a couple of presentations here just to see if we can get the right assessment. So this is the androgen story as told on page 1 of the summary page. What I would ask myself here is this an androgenic presentation? Well, how old is the patient? She's 71. So this is, somebody who is menopausal and been menopausal probably for almost 20 years. She is overweight and she struggles with excess facial hair, right? So we can see that her DHEA looks normal for age. This purple band is the postmenopausal range. So she is in it. She's also in the premenopausal range. So she's in that overlap. So she's a robust androgen profile, adrenal androgen profile. However, her testosterone is pretty high. So I would call this a very androgenic picture. And her 5-alpha androstenediol, similar to how her DHEA is looking, is also sort of similarly hanging out in both the pre and post menopausal ranges. But she has a pretty low 5-alpha reductase activity. So the assessment would be that she has high adrenal or adipose tissue testosterone production, not exacerbated by 5-alpha reductase activity, but we want to figure out why this testosterone is high, right? In a 71-year-old, the most common reason, if it's not due to transference from like a topical testosterone from a partner or a family member, it is often insulin and glucose dysregulation. So it's something that we might see in our patients who have type 2 diabetes or glucose dysglycemia, might have high testosterone on a Dutch test. How about this one? Is this an androgenic presentation? This is a 34-year-old female. She struggles with acne, excess body hair growth. On the left, we have androgen production. Actually looks like a pretty normal amount of androgen here. Top of the range for DHEA, but could be normal for her. Testosterone, certainly not climbing out of its range, but when we look at 5-alpha androstenediol, it's really high. So testosterone's forming a lot of DHT in the tissue, and that's a strong androgen. So the 5-alpha reductase activity, when we look at the DHEA metabolism and compare the androsterone to etiocalanolone to get this ratio, we can see that they have a lot of 5-alpha activity, mostly androsterone here compared to etiocalanolone. So the assessment would be normal adrenal and ovarian. Well, testosterone is kind of a combination of ovarian and adrenal production, but fairly normal production. But the issue is with 5-alpha reductase activity in the tissues. So we know we would approach that just slightly a little bit differently. Okay, so here is the 5-alpha reductase summary slide. Notice the main drivers of 5-alpha reductase activity in the body, and stress is a really common one that I want to spend a little bit of time unpacking today, because on a Dutch test, we're looking at so much more than just androgens. We're looking also at the cortisol story and the adrenal stress story. With stress comes high cortisol. So that's kind of the connection. We're going to look at a couple of high cortisol situations that are associated with high 5-alpha reductase activity. All right. So when you see high free cortisol at the tissues, that could be stressful enough to push up 5-alpha reductase activity in said tissue, even if the metabolites of cortisol coming from the liver and the adipose tissue are not also high, right? This is your low cortisol clearance rate patient, but these free cortisols should make you concerned, especially if you have symptoms presenting like acne or scalp hair loss, and hirsutism and irritability and all of those high androgen symptoms, and you see an elevation throughout the day in free cortisol. That tells you stressors are at play. When metabolites of cortisol are high, even if the free cortisol pattern is not showing elevated, right? And it's not. It's pretty tepid, sort of flattened down cortisol slope, maybe a little high at dinner time. But overall, when we add all those points together, not high at all, right? Mid-range. But the metabolites are elevated, the clearance rate is high. This is an early adapted response to inflammation, maybe, or another systemic stressor, could be insulin. But looking for those highs, this person could have a driver for androgens. Similarly here, this is a little easier to spot because they're not only high in their free cortisols, but also high in metabolites. So they're making it and clearing it at about the same rate. This is a high stress prior to the adaptive state, which is a little bit harder to find, where you're looking for the high cortisol. Here, it's high everywhere. Easy to spot. And cortisol dysregulation is a sign of stress, but it means that there's something else under the surface. Cortisol itself can thin the hair follicle. It disrupts the hair growth cycle. It itself has plenty of, androgen exacerbating properties on its own. But when we look underneath, why do we have high cortisol This is what's underneath. There's autoimmune, and there are stressors that might be physiologic, or they might be in the environment, right? We could have sleep apnea, we could have infections, anxiety, family stress, work stress, toxicity. So look for possible reasons why that might be happening when you see high cortisol. So we start by treating the stressors that you know about, of course, and that should normalize cortisol and DHEA if you're successful. And lowering DHEA alone will help with high androgen symptoms if that's one of the causes for that person. But getting cortisol off the table will quell 5-alpha reductase activity, and altogether you get an alleviation in those symptoms, right? So we often start with stress and cortisol with high androgens. So there are a few additional drivers of high androgen symptoms that aren't androgens. The first one to know about is prolactin. And we don't look at prolactin on a Dutch test. So you might ask, why are we even talking about prolactin then? But you can get some clues to high prolactin when you do really any hormone test. But on a Dutch test, you might have a clue that prolactin is a player for somebody if they have the presence of high androgen symptoms despite having kind of normal or low estrogen and normal or low testosterone and DHEA output, right? With like high androgen symptoms, but I don't see any high androgens here. And there's no imbalance in the way it's being metabolized. And like I'm coming up with very little. Think about prolactin. Especially with low estradiol, because prolactin, when it's high, blocks gonadotropin releasing hormone, or GnRH. It can mess with our LH and FSH, driving it down, and it can lower estradiol and testosterone considerably. So be thinking about that when you see low sex hormones and androgens. Now, DHEA is often driven by prolactin. If prolactin is high enough in the bloodstream, you will actually see higher and even dominant sulfated DHEA in urine. So look for DHEA sulfate dominance. Another marker that you might see is low HVA in the organic acids. This is a dopamine metabolite because high prolactin suppresses dopamine. And then, of course, a low cortisol clearance rate, like in this example, TSH, when it's elevated, you know that there was at least a transient prolactin rise because TSH is co-released with prolactin from the pituitary. So that's really important to know when you're dealing with someone where you're really kind of trying to stepwise figure out why somebody has symptoms. Maybe it's hair loss. If you see this sort of hypothyroid looking cortisol pattern with a super low cortisol clearance rate, you should be maybe thinking about prolactin as an additional driver. Okay. Second non-androgen driver of high androgen symptoms to keep in mind is dysbiosis. On a Dutch test, you can assess urinary indican as a screening marker for gut dysbiosis, but if you suspect that it's a driver, you'll probably want to do a stool test whether this marker is elevated or not, right? So in this case, the indican is high, but even if it was within range and this person maybe has all normal markers otherwise on the Dutch test and their prolactin is totally normal and there's really no good reason that this person would have a lot of high androgen symptoms, but they do have some gut symptomatology, go ahead and do that stool test. Not all gut bacteria are indican makers. I mean, there are some, right? E. coli and Clostridia, and there are several that will increase indican considerably in the urine. But there are some characteristic gut microbiome shifts that are associated with high androgens, metabolites, and even just high androgen symptoms. So don't miss that. So let's dig into how the Dutch test can help you out clinically. And we do have some changes to the report that I just want to highlight while we've got each other all together. And it's important to know that this test panel assesses a lot more than just parent hormone levels in transit to target tissues, right? Because we could pull that out of serum, honestly, and can sort of put together for somebody what's going on as best you can. But there are things you would miss, and things that you can't rule out necessarily by looking at a simple hormone test in serum. So the Dutch Complete for both females and males is made up of a summary page plus 3 component panels. This is our new summary page. The sex hormone panel follows. Adrenal panel after that looks at free cortisol diurnal rhythms and cortisol's metabolic profile and DHEA, and the organic acids profile. And the Dutch report, if you're not familiar, it conveys hormone ranges in a dial format that takes some people a little getting used to, honestly. So here's the female total DHEA production dial, but all of our androgens and estrogens are depicted within these dials on the expanded hormone pages. So this dial has 2 age-dependent ranges embedded into it. So there's a green for the premenopausal range. So, higher hormone output when we're younger. That range is based on 18 to 40-year-old females who were premenopausal and normal, relatively normal physiology. And then the postmenopausal range is this purple range. So that's kind of the theme for postmenopausal is purple. When you fall into the postmenopausal range, the dial nose will change into the purple color so that you know that you're in the postmenopausal range. Once you're up into the premenopausal range, that dial nose will turn green. So you can easily spot imbalances, highs and lows. Highs will show a red dial nose, right? If you're too high or too low. So it's very easy when you're looking at a Dutch test using the dial gauges to see what range somebody falls into and whether they're high or low. So first, let's orient to how androgens are reported on the Dutch test, starting on page 1, because this is a little bit new, I think, for a lot of us. A person's androgen story, their testosterone and DHEA production, and the way they metabolize their androgens is told here on the left in the outline section. And we have hormone production on the left. And then we have hormone metabolism on the right. And that's true even for like the above section, the estrogen section. We have hormone production and hormone metabolism, right? Phase 1 and phase 2 detox. Same thing with the cortisols, cortisol, free cortisol production through the day, and then metabolism showing up on the right, right? So on the expanded sex hormones page 2, the androgen story is here on the left-hand side. And the total DHEA production assessment here is made by adding up the DHEA sulfate and DHEA's downstream metabolites, androsterone and etiocalanolone, just like it always was. But it's the total DHEA in urine that correlates best with serum DHEA sulfate in patients with normal aromatase activity. So that's good to know. Sometimes we have serum DHEA sulfate results in our hand, and we look at the DHEA sulfate and we say, that DHEA sulfate's really low. But the serum says that their DHEA is normal for their age. What gives? You really have to look at the total DHEA production, where it falls, to determine what you would expect to see in serum for DHEA sulfate. Because remember, urine is post-uptake and utilization. The serum is much more what was produced and what's on its way to transit tissues, or what's on its way to target tissues, not transit tissues. All right, so let's just quickly cement this in with the androgens comment section in the Dutch dozen section of the report. So if you're getting this report for the first time and you're thinking, gosh, I just need to orient myself to this summary page. This summary page is quite comprehensive. It really pulls together every important detail that you'll need to get started with treating the patient. So this section on a female report is the second section down, goes through the androgens story. The first little section here comments on any symptoms that the patient might have reported that go with high or low androgens, or it might comment on the patient's age range and maybe perimenopausal status. So So make sure you check out that comment section first. Then each section begins to comment on each element of that hormone story. So the first hormone in the androgen story is DHEA. So our first comment comments on the total DHEA production. And it's specific to the patient. So if the patient is 70 years old, we'll be assessing their adrenal androgen levels based on the menopausal range, and that makes sense, right? Then we move on to testosterone, also normal for a cycling female. This person is perimenopausal, 49-year-old. And then we move on to the androgen metabolism. So, importantly, despite normal testosterone levels, we can see the 5-alpha androstenediol level is high. And applying what we learned already about DHT activity in tissues, we know, 5-alpha androstenediol can be high because you have lots of testosterone production, or it can be high because you have a lot of 5-alpha reductase activity in the tissues. Right? I think it's the latter in this case, right? There's more 5-alpha reductase activity in the tissues. And that makes a difference when it comes to treating the patient. Are we knocking down testosterone production, or are we going after the metabolism? We also have an advanced insights section at the, just behind the Dutch dozen comments that ties together some of the deeper concepts that are associated with each hormone story. Some of us like to dig in on cortisol, cortisone balance, and even 5-alpha reductase activity in the progesterone metabolism, if we're thinking of using progesterone therapy and kind of understanding where that's going to go. That's the advanced insights section here that you'll want to look at for those insights. So let's get into some cases where we can kind of look at this in action. Now that we understand what the major players are in the androgen metabolism. And I pulled a good one that combines PCOS and fertility into one case. So this is a 32-year-old female presenting with irregular cycles, very irregular, 15 to 90 days, I think is the longest she goes typically. She has acne and hirsutism that bring her in. She has some difficulty with her weight and she's tired. She complains of irritability and mood swings, and her main goals are to manage these symptoms. And she would like to fall pregnant really within the next year. So she's in to detangle some of this stuff. At the time, they were able to coordinate serum labs with Dutch testing, including cycle mapping, which was nice. They found a very PCOS-looking profile, you'll notice, with the high free testosterone. So here's their serum panel. They did a free testosterone with the total. Total actually wasn't ridiculously high, but you can see she's got a pretty low sex hormone binding globulin that leaves her a lot of free testosterone that goes above its normal range. Her DHEA sulfate was really high, almost twice again the top end of the normal range. LH to FSH ratio was elevated. So a lot of the typical things that we might see with a metabolically driven PCOS we're seeing with her. Also, progesterone was anovulatory. So a lot of these they were looking at on cycle day 3, but estradiol or not estradiol, but progesterone they pulled on day 21. So we'll want to look for that to correlate with what we see on the cycle mapping test. But they did find a very low anovulatory value for progesterone in the serum on day 21. Thyroid panel was totally normal, so that's good, especially whenever we're thinking about what might be driving somebody's difficulty losing weight and fatigue and mood fluctuations. We might think about a thyroid panel. Hers is normal. Most of her markers fall into that metabolic and inflammatory kind of etiology, probably, and that is affecting some of her androgens and her fertility markers. So glucose was a little bit high at 100. This is one we might think of in the pre-diabetic category. Her insulin was pretty high. We'd like to see that under 6 if we can. She's at 24 for fasting insulin. And then her A1C is on the upward trajectory. She's at 5.8 in pre-diabetic territory. Lipids are out of whack. LDH is high, or not LDH, LDL is high. Triglycerides are up, and the HDL we'd love to see even higher. And importantly, she's young and her HSCRP is elevated. So the goal would be quite a bit less than 1. She's up at 3. So all of these are opportunities to remove some of these obstacles to proper cycling so that she can have a baby this year. Her AMH was elevated, also pretty consistent with PCOS presentation, high AMH. If her AMH was low, we would be worried about dwindling ovarian reserve. It looks like this is something we can work with. 17-hydroxyprogesterone tells us we're not dealing with a congenital adrenal hyperplasia or anything like that, which is good. And her prolactin was normal. So a lot of times with fertility, we'll go in and look at prolactin right off the bat because that confers high androgen symptoms and it thwarts fertility efforts in kind of a different way by lowering LH and FSH. But we see her prolactin is normal, and in fact, her LH and FSH, certainly her LH, is elevated. So I think we know what's going on here. Okay, so they ordered a Dutch cycle mapping test and a Dutch complete. And on the left here is the cycle mapping test. She collected samples across 30 days. So in the graphs up top, we can see the estrogens are fairly static, right? She's even at baseline at her follicular day 5, she's up above that follicular range. It's between the dashed lines is where the ranges typically fall. And so even at her lowest estrogen kind of a day, she's sort of at the higher side for her free estradiol. So that's important to know. And it never actually goes down into the normal follicular range. And she has a little blip here, like maybe we had a baby beginning of a follicle developing, but obviously there's something disrupting follicle development if she doesn't get that clear, nice rise. And certainly she does not have a rise in progesterone that shows that progesterone occurred at all, right? So a similar pattern of no change throughout the cycle. And on the Dutch complete summary, we can see she's hanging out in that menopausal or anovulatory low range for progesterone. Anybody who's not done a Dutch test before, on the summary page, we have a calculated value. It's a progesterone serum equivalent, and it's calculated from the alpha and beta pregnane dial that we test using urine, right? Progesterone we can't quantify in the urine, so we have a serum equivalent calculation. So that's really what you're looking at on the summary page. If you would have drawn her serum on the day of testing, that's what you would have gotten probably. So, and this is all from our published research, and all those papers are open access, so that's something that you can find. And if you're interested in reading it and you can't find it, let me know. I've got our email at the end of this presentation. I'm happy to share that with you. So this essentially provides you an idea that this progesterone is low and unchanging throughout the cycle. So with a cycle mapping, when it's ordered with a Dutch complete, we find the rise of progesterone and we pull the day of progesterone's zenith during the luteal phase. And that's the day that we pull over to test out and report all of the metabolites of progesterone and estrogens. But in her case, her highest day of progesterone output, ironically, was day 5. So that's the day that we're looking at here. So that's how you might unpack this if you do a cycle mapping with a Dutch complete. So moving on in the estrogen story, we can see that her metabolism ratios fall into their normal ranges with a bit of room to improve if you're being picky. DHEA production is pretty high, really high, and that mirrors what was found in serum. So if we can knock her DHEA production down, you might expect that her cycle regularity would improve, insulin sensitivity is improving, acne and hirsutism are getting better. So this is going to be a priority. So approaches to high DHEA are many, but one sticks out to me. This is from our treatment guide. The blood sugar balancing in particular, because she had such a strong predilection towards dysglycemia in the serum labs. I think this is probably why the provider decided to double down on insulin resistance supports. Incorporating insulin sensitizers into the plan could be a good way to restore her cycles and her fertility. So moving on to testosterone, it's really low, right? That's weird. That should make you think, huh, that's weird. DHEA is high, testosterone is low. So this should make you think about UGT deletion. And this is why I wanted to include this one. So look at the EpiT here at the bottom. There we go. I've got it highlighted for you. That's pretty robust. So that's the real story. This is what she's making probably for testosterone, is tip top of the range. And remember, her free testosterone we know was high in serum. So we are definitely thinking about UGT deletion. So we must look at the 5-alpha androstenediol as her tissue activity from testosterone. It's unaffected by UGT deletion, gloriously unaffected by UGT deletion. So this is going to be where we base our assessment for testosterone. All right. 5-alpha metabolism of DHEA also sort of reiterates that issue with 5-alpha reductase activity piling on to the high adrenal DHEA production, right? She's making a lot and making the strong sauce out of it. So of course she has acne and fertility issues, right? So when we look at approaches to high 5-alpha reductase activity, we again find her likely drivers: insulin, inflammation, maybe adipose tissue dysfunction. And let's look at cortisol, because whenever we see these types of stressors influencing our androgens, often we'll see cortisol irregularities. The diurnal pattern for her is flattened down, with the highest point all day coming in from overnight while she was asleep. Right? Remember, the waking sample with the urinary free cortisol contains all the cortisol that was produced, circulated, and excreted during the night of sleep the night before. So this likely is playing a role in her morning fatigue. So we might think about adaptogens on top of lifestyle supports to kind of speed along that HPA recovery from long-term stress. And high cortisol clearance rate here, elevated cortisol metabolites here compared to the free cortisol. And you don't have to eyeball this anymore because we have a cortisol clearance rate. And we can see that it's very high, right? This is probably contributing to her daytime fatigue. What causes fast cortisol clearance? You guessed it. Blood sugar, insulin dysregulation, inflammation, right? That adipose tissue pulling cortisol out of circulation faster than she can make it and replace it. So we can incorporate some of these botanicals maybe into the plan to improve cortisol clearance and help her lose a little bit of weight and improve her metabolic function. And then at the bottom of each of the summary pages is if organic acids have been ordered, and on a Dutch Complete, you do get an organic acids panel, you'll get a rundown of what was abnormal. So we can see gut dysbiosis is showing up here for her pretty strongly, maybe an evolving B12 deficiency, and her neuroinflammation marker, which is quinolinate on our test. I'm thinking gut dysbiosis is maybe behind, maybe as an ultimate driver, those high androgens, cortisol, insulin resistance. Maybe we can tie that together with a foundational treatment plan that goes after gut. So we can take a quick look at the expanded hormone panel on page 2, but we can tell that it's well summarized by page 1. Her androsterone is high. That's up here. So we have a lot of DHEA sulfate, a lot of androsterone, but remember her total DHEA production was very high, and we saw that high 5-alpha slider. So we already kind of knew that her androsterone was going to be high and dominant, but there it is. You can come and you can see this is a nice representation of how out of whack these androgens are compared to, look at all the green on this side, green dial noses, and the purple is even low. So just really a much quieter picture when it comes to estrogens and progesterone compared to the androgens, right? This is a more adrenal-driven PCOS. And then on the expanded cortisol page or adrenal page, we can see how fast clearance of cortisol at the liver and adipose tissue, there's the fast cortisol clearance, is also occurring in the kidney, right? So she's low in free cortisol, but sort of high in the free cortisone at each time point. So it's very consistent hypermetabolism that we often see with metabolic dysfunction. Okay, cortisone dominant. So what they decided to do was initiate an aerobic exercise plan. That was one thing she wasn't doing. She felt like she was eating really well, and she, her diet diary sort of proved that, but she was not doing any sort of aerobic exercise. That was where they started. 30-minute session, 5 days a week, started with walking outside when it was possible. And they started by ordering a stool test, and they felt like treatment there would form the foundation for everything else that they were going to do. They did add in some metabolic supportive therapies to help get her insulin sensitivity up, a curcumin green tea combo product to decrease her cortisol clearance rate and improve inflammation, and an adaptogen formula that incorporated some of the blood sugar balancing adaptogens and improve her daytime energy. And then I think, having somebody leave your office with more than 3 or 4 things is probably problematic, at least initially. And, we can consider 5-alpha reductase inhibiting herbal supports or cyclic progesterone as bridge therapies. Really, you want to make sure that people are having their initial symptoms addressed in some way before they leave the office, if you can. Otherwise, you might lose their trust. So these are all possible, but they would be bridge therapies while you're working on the underlying causes. And what she's looking for are for her cycles to become more predictable. That's a good early sign. Her skin should clear a little bit. Those would be encouraging signs. Her body composition normalizing will take a little bit longer. Energy levels and sleep and mood should improve pretty quickly on this type of a plan where you're addressing adrenal stress and insulin sensitivity. And then they want her to return for stool test results and a good GI restoration plan to underlie everything that they're going to do with insulin sensitivity and androgens. I also have a hair loss case for a 37-year-old female. How are we doing on time?
We are doing good. I think we are all having a party here. So
All right.
carry on, no stress at all.
Excellent. Good deal. Well, I'm just going to keep going, and maybe we'll have time for some questions at the end.
And remember that we are recording, so people can always go back and revisit, and I think they have to revisit no matter what. So
Good.
Yeah, there are some Q&As at the end.
Sure. Great. So 37-year-old female with hair loss. She's been fighting hair loss for the past 4 years and gaining weight around the middle, can't get it off, and nightly having trouble getting to sleep. Once she's asleep, she's okay, but falling asleep has gotten tough over the last few years. She takes some vitamin D, but that's about it. And the hair loss is kind of frontal, maybe a bit in a male pattern, but it's more just sort of thinning and irritating to her. She brought some testing in with her that showed some mild dysglycemia, some deficiencies, and some inflammation. So her folate was low, zinc was low, HSCRP was high. So you can kind of get a sense that maybe there's some deficiencies and inflammation underlying, maybe some insulin resistance. But notably, her testosterone and free testosterone in the serum were totally normal. So she sort of was told she was fine. Also negative were her thyroid labs, iron panel, lipid panel, ferritin, autoimmune screen, no overt infections. And she was pretty upset, to be told that they didn't know what was going on, and her hair looked fine to them. So for this case, we'll be reviewing the patient's results using the Dutch dozen, as we'll be teaching it over the next year. You'll hear Mark talk about it an awful lot. The Dutch dozen is an interpretive framework that simplifies Dutch test interpretation, and it really focuses on the summary page, which anybody who's done a Dutch test previous to this new report is used to the summary page being a nice highlights page. It gives you, a few markers pulled forward that tell parts of each story, but it's never been a true summary page until now. Now we have essentially 12 key assessments. So we'll just kind of start with that. So we have estrogens up top, and we have 4 key elements in the estrogen story, right? We have production on the left and metabolism on the right that we alluded to earlier. And then the androgen story, same thing. We have production of DHEA and testosterone on the left and androgen metabolism on the right. And then same thing with cortisol. So the estrogen story is told by the E2 level and its balance with progesterone, the phase 1 and phase 2 metabolism, and then the androgens, and so on and so forth, right? So let's start with the estrogen story first for this patient. We can see her estradiol level is totally normal. Progesterone level, totally normal. So we're not really looking at a PCOS case like we were with the last patient necessarily. Estrogen metabolism, man, stellar. An awful lot of this 2-hydroxy dominance here. And methylation activity is sitting right in the center of the population percentile. So pretty good methylator. Not a lot to get mad at here in the estrogen story. And you can look at that in many different ways. Some people like to create a checklist. I think you'll be able to probably use these hormone stories and say, well, okay, estrogen metabolism gets a gold star. Estrogen story gets a gold star. Now let's look at the androgen section, which is next. DHEA falling within the normal cycling range. Looks good. Same thing with testosterone. You can kind of see why she got sent away from traditional medical. But 5-alpha androstenediol, when we dig in with the urine, we can see dihydrotestosterone production at the tissue level is actually really high. So normal production, high 5-alpha reductase activity, also in the DHEA. So this is a highly androgenic presentation, but not because she's producing a lot of androgen. It's because she is making downstream metabolites at a higher rate than the average bear. So the assessment is androgen metabolism rather than androgen production is driving this train. More potent androgens here. Okay, cortisol. We see elevations in free cortisol. And when we know that, because now you can eyeball, this is within the normal range. We know that because it's green plot point, even without looking at the table. She rises to a pretty high place. We know she's high because she's red. Same thing here. She's high at night before bed. So she's got some elevations. This is probably why she has trouble going to sleep at night. And so is metabolized cortisol here, also pretty high. Here's metabolized cortisol. So she is making a lot of cortisol and metabolizing a lot of cortisol at pretty normal rate of clearance. So that's good to know. This is enough cortisol to contribute to hair loss. That's the bottom line. So the assessment here is that cortisol output is high. This is an adrenal stress picture for sure. And cortisol itself can disrupt the hair growth cycle. It can thin the hair follicle. It has many different direct mechanisms for disturbing our hair growth. So we have to think about that. But we also need to think about it one level deeper, which is what's driving those cortisol elevations. And some of those things, insulin and inflammation, also have their own effects on the hair follicle and hair growth. When we look at her oats abnormals, we can see immediately that she has a biotin deficiency. That can also contribute to hair loss. So remember, she had low zinc, low folate, low biotin. So the zinc and folate were found in the serum. And here we have biotin low. So all of this can contribute to hair loss. So we're thinking about her case altogether. She's got the high androgen metabolism. Oh, I wish I would have written metabolism here. High androgen metabolism, high stress, high inflammation. She's pre-diabetic. She has all these deficiencies and high cortisol. Every single one of these could be contributing to her hair loss. So if we build a plan around those areas, her hair loss should completely resolve. But where do we start? I always think about pulling out the Dutch interpretive guide. I hope everybody has met the interpretive guide. We will be putting out a new version or an up version of the Dutch interpretive guide to go with the new report. It's a fast follow, which means we'll be seeing it this month or even early next month. So once we confirm androgens or androgen metabolism are behind the clinical picture, then it's nice to use this clinical resource to help identify underlying causes, because sometimes it's not like in the top of your mind, the things that drive androgens maybe. And so this puts it kind of in a succinct way. So page 59 talks about contributors to 5-alpha reductase preference in the androgen metabolism. And you'll notice, some of these things she's dealing with: inflammation, blood sugar dysregulation. So we want to treat at the root as much as possible. Use the treatment guide as well, especially if you're new. The provider in this case did use a 5-alpha inhibiting herbal support product, and we do have some before and afters for those, which is kind of nice. And incorporated insulin resistance supports into the plan as a way to improve her metabolic and underlying inflammatory etiology as well. But the 5-alpha inhibitor support product had these 3 herbal supports: saw palmetto, stinging nettle root, and pygeum. Now, pygeum, I think, is an endangered plant. We always like to be mindful about maybe not using so much pygeum anymore. It's still found in a lot of our 5-alpha reductase inhibitor products because it does work so well. But I would encourage folks to try to find maybe a different product that doesn't have that in there. But they did do a Dutch retest. This is her original result. And then on her redo 3 months later, she's already decreasing down in her 5-alpha reductase activity. So before, she was in the 91st percentile, higher 5-alpha than most people, to being lower than the 50th percentile. And you can see where it hit her the most. So it really pushing more metabolism down the beta pathway, right? Even pushing this 48 up into 86. And we don't mind that because the 5-beta is basically an inert metabolite. It does not bind to androgen receptors. And the 5-alpha androstenediol has normalized to 20 from almost cut in half. That's significant. So they knew they were on the right track at 3 months. Hair is difficult because hair takes a long time to see a real improvement. Maybe 6 months, you can do a good initial assessment. So we're looking for markers to show us we're on the right track. Doing some serial Dutch testing can be helpful to see if your therapies are working and what your prognosis is before you get to that 6-month mark. Similarly, they did a cortisol lowering formula that had phosphatidylserine and L-theanine. You might be familiar with it. It has also ashwagandha in there. They were able to gain some traction on lowering her free cortisol levels as well. Yeah, you can see where she was last time, and then now she's falling into the normal ranges all day long. The 24-hour is a good way to look at it too, right? She's falling right there into the normal range. So the final plan was to draw up some serum labs at this 3-month visit for metabolic improvements, but she's to return in 3 more months for a full reassessment of hair growth, even though she's had some initial improvement. Remember, hair growth is slow, and they want her to return for a repeat Dutch in 9 months so that she's getting a repeat Dutch 1 year from her initial test. And that brings me to the end. Thank you so much for your time and attention. I hope this takes a little bit of mystery out of the new report, but I'd like to open it up for some questions if we've got them.
Excellent, Allison. Thank you very much.
Absolutely.
Really nice to get the new report, because we did send out an email last week about the new report where Kelly, one of our clinical support people, just did
walk you through.
a video, and yeah, so that's some information in your inbox if you haven't seen it already. But this was really nice to also see it demoed so that we get used to it. I mean, it's a question of like repeating experience.
That's right.
Yeah, so this was really nice. Thank you. So a question came up, and it's a question that often comes up, and I think it would be nice just to hear your take on it in regards to women on HRT and or not and or but or contraceptive
Uh-huh.
pills, and how you think you can read the Dutch report when so basically using for monitoring HRT, I guess, and in regards to contraception, if the woman is has signs of high testosterone or
Yeah.
signs of yeah, hormonal issues.
Sure. And I think it depends a little bit on the birth control too. I think the oral combo birth controls that have ethinyl estradiol in there, as well as a progestin, one of the main mechanisms is ethinyl estradiol. When you swallow it and it goes through first pass metabolism, it increases the production of sex hormone binding globulin. So we get really high levels of sex hormone binding globulin that for some patients never return to normal. They're always a little bit higher than they would have been if they had never taken the birth control pill ever. So it has a really profound effect there. So what we expect to see in urine is lower testosterone and testosterone metabolites, because in urine we're only seeing the bioavailable free fraction. Right? So anything that's not bound to sex hormone binding globulin has the opportunity to be taken up into tissues and metabolized down. Anything that is attached to sex hormone binding globulin, and if it's high, most of it's going to be attached to SHBG, we're going to see low levels in urine. So that's important to know. Now, some people are on low dose oral contraceptives, like low estrin is one, or I don't know, there's a bunch of different brand names for it, but the ethinyl estradiol dose is a little bit lower, and often we'll see pretty intact estrogen levels and testosterone levels, especially in patients who are maybe have a higher BMI, but sometimes we'll see it when you don't expect it. So that dose isn't quite high enough to raise the SHBG in the same way. And they can still have persistent high androgen symptoms sometimes. And it is helpful on occasion to do a Dutch test and look for the 5-alpha androstenediol as the evidence that we're still having a lot of that tissue conversion. Sometimes we just want to cross it off the list and rule it out, right? So you might do a Dutch and say, well, it really doesn't look like the androgens are players, but we see dysbiosis and B6 deficiency, and we see cortisol dysregulation. And, because we're not only looking at sex hormones, you have the benefit with a Dutch of putting together other parts of the story, even if they're on birth control pills. When I think about hormone replacement therapy, because there's so many different deliveries. So, if you have somebody on oral estradiol, it's going to be, similar to oral contraceptives where you're swallowing that estrogen, SHBG goes up. A lot of times the urinary androgens will go down. And so those are all kind of the same considerations that you might use with oral birth control would apply to oral estradiol. It's much more quickly reversible with oral estradiol if you come off of that orally too for 2 or 3 days. Usually the SHBG can come down a little bit faster than it would with ethinyl estradiol. Ethinyl estradiol is such a strong estrogen. Those effects are much longer and stronger and more profound. But with transdermal estrogens, we don't have that. It doesn't raise the SHBG like the orals do. Androgens are ripe for interpretation with transdermal estrogens on board, and highly encourage people to use Dutch testing with transdermal hormones, because we've done extensive study on our methods and what you typically see with transdermals on board: gels, creams, patches.
And obviously you want to see the pathway
Metabolism.
that it's not
Yeah,
feeding down the
exactly.
whole hydroxy pathway, and so that you can kind of support that pathway and support the cells and body and DNA of that
Exactly.
specific
And be
patient.
preventive. Yeah.
Yeah, exactly.
Mhm.
And then obviously, like if you have someone who's just started on transdermal estrogen, then you would do it after 3 months. So
Yeah, I think 3 months is a good time to look in, and that way you know what types of sort of add-on therapies that you would want to apply. You can also figure out if you're underdosing somebody in terms of like bone support. You know, we want to see people above a certain level on a urinary estradiol, and you know, if you're not quite getting over that threshold, you might be leaving somebody sort of untreated for
but
osteo.
but
Yeah,
for that, just to take you can do an FSH to see if it's come down
coming
again.
down.
So
Yep,
that you
absolutely. Yes, in serum, and there's some really nice serum correlations too with urine estradiol as well. So, you know, um, so getting into those right ranges and watching the FSH come down. Absolutely. Yeah. Find all kinds of good signs to monitor.
super.
Yeah.
So there was just a question a bit best day to measure prolactin, and I guess time of the day as well.
Yeah, so I typically think about prolactin. I will usually draw it on a day 3 at the same time as LH and FSH, partly because prolactin, when it's too high, will suppress LH and FSH, and I like to look at the 3 together. And often I will draw a thyroid panel that same day too, because thyroid, hypothyroid connects to high prolactin and low LH and FSH as well. So they're all connected. So I usually like to do an early follicular and usually an early fasting sample.
Super.
Yeah.
So, just because it came up on the screen, and I think it's a good question,
Yeah.
like the Dutch mapping, so the question goes, and would that be good for someone suspecting endometriosis? But just like a quick, like, when would you go for uh,
Mapping the whole thing.
the whole cycle, and when would you just go for?
Yeah, that's a good question. I think when there is cycle irregularity, the cycle mapping is really important because anytime you feel like you would be left with questions in your mind when the results come back. So if you have somebody with pretty regular cycles and they're always about 30 or 35 days, and you can be pretty sure that you've caught them in their mid-luteal phase with a single day mid-luteal collection. And you know, if you got those results back and their progesterone was low, you'd be like, oh, this is probably a luteal phase defect or luteal phase insufficiency. But if you have somebody with irregular cycles and they maybe go from 15 to like this example that we looked at today, 15 to 90 days, and you're trying to have them collect a Dutch test, and they're doing an ovulation predictor kit, but their LH is positive every day, and they can't find like a clear sign of ovulation. Those are really great candidates, I think, for doing a cycle mapping, because then you get that spread of data over 30 or 35, 40, or if you do the long cycle collection over 60 days, and you can really see those variations. You can see easily if there's a cycle to behold. Sometimes there's not. Sometimes there's just an estrogen part of the cycle and no progesterone. Sometimes there's the tiniest progesterone rise, but then it goes away really quickly. And it really changes the way you would treat that patient and how you would assess their data. Otherwise, the data from a single day collection might seem a little arbitrary. So that's what I tell people. They don't always love that answer, but if you think a single day collection might give you more questions than answers, do the cycle mapping. And that way you know that what you're looking at is a mid-luteal sample, or there was no mid-luteal sample to be had. And the day you're looking at is as good as any other day that they would have collected that. So
Yeah, and also what's the aim with the treatment? I mean, obviously, if it's pregnancy, you want to know when that ovulation is happening and if it's happening,
Yes.
uh, for sure, and then to support that. And yeah, but thank you for that answer. So, and then obviously, like the Dutch interpretation guide we will upload into VMS. The new one we will upload as soon as it's there. We'll probably put a note in the system to say, right, it's there. And also with this recording, we will send out the Dutch interpretation guide that there is now. I was just checking VMS. We removed I guess one of the older versions, and for some reason it hasn't been replaced. So we will put that in tomorrow when maybe my team is already doing it now.
Oh, good.
So,
Yay.
but it definitely should be there, and then but it won't correlate with what you've seen on the screen now because it's the updated report that you've just seen. So,
Yes.
but I think we should call it now. It's getting evening here, and but it's been an amazing webinar, and as usual, it's always lovely to learn about hormones, the complex picture, but so we can't get enough education around understanding hormones. I know
Yeah,
one question just a second. There was one that came up because it was about hair. Let me just see if I can find it.
sure.
Oh no, now I can't see it. Whoever asked the question, something why I think it was like, why does some PCOS have hair loss and others don't? I think that was the question.
That's a
Can we
great
take that at
question.
the end here?
Yeah, I think, with hair loss, there needs to be some sort of combination of imbalance, but also somebody's unique physiology coming into it. Some people have a thinner hair follicle to begin with, and others have thicker, just sort of coming in genetically. But I think, like the case we looked at today, where you have this conglomeration of all these different drivers, the nutritional, the dysbiotic, the high cortisol and the high androgen. I think when you add all of that onslaught together, it can lead to hair loss more so than even just the high androgens themselves, for some people. So that's the importance of kind of looking at the patient right in front of you. And some people just are lucky and have a really great head of hair, and others really struggle with every little fluctuation in their hormones.
Okay, thank
Yeah.
you. And just to those who didn't read the notes, that UGT2R17, the deletion or insertion you can find in our DNA hormone report. So if you need to know that as a clear answer, then you do a Dutch test and you pair it and combine it and add a DNA hormone to the order in the system. So the
Exactly.
perfect pair.
It really is. Yes. Yeah. And
And
yeah. Go
yeah,
ahead.
Allison, it was really nice being educated by you. Thank you for sharing your brain with us all.
Thank you
And
for having me. I'm sorry for my tech difficulties this morning, but I'm glad we got to connect.
no stress, you went straight on. You knew what the party was about, so
That's
all
right. Well, anytime. Good to see you guys. Thank you so
Likewise.
much.
Take care. Bye.
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 If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.